Today is all about Mannitol. Many will be familiar with systemic or intravenous Mannitol. I don't blame you for that because you need that in increased intracranial pressure, cerebral edema treatment, and so on. How about per-oral Mannitol through inhalation? Bronchitol for cystic fibrosis as mucolytic agent, Aridol for bronchial challenge test to make diagnosis of asthma. If you are familiar with that, that is fine. What about Mannitol in gums, in candies, as sweeteners, right? In tablets and capsules to mask the bitter taste? How about that? You're not familiar with that, right? I'll take you through everything that Mannitol could be used for. The adverse reactions, warning, how to monitor Mannitol, and then certain complications that may follow certain procedures that Mannitol could be used for. But before going further, let me welcome you to my channel. I'm saying a big thank you for visiting. Please remember to subscribe. Without further ado, let's go in. Mannitol. Mannitol has dual roles. As a sweetener found in gums, in candies, and as a sweetening agent, even that diabetic mellitus patient could tolerate. Why that? It doesn't raise blood sugar. It's found in tablets and capsule as diluent. Why that? To mask the bitter taste. So, whether you like it or not, whether you are aware, you are not aware, you don't have to be a physician, you don't have to be a nurse. Everyone, one way or the other, we are in contact with Mannitol. Also, as a medication, this time it could be systemic or intravenous, could be as irrigant, used by urologists, or could be per-oral, or by inhalation. The people with cystic fibrosis who make use of it as mucolytic agent, or in diagnosing asthma through bronchial challenge test. So Mannitol is pretty helpful. At a glance, you can go through my first note here. I will not waste your time here because I'll still go through each of them later on, but just to let you have an idea of what we're going to be dealing with. There is systemic Mannitol or intravenous Mannitol. There is per-oral Mannitol given through inhalation, cystic fibrosis in bronchial challenge test, Bronchitol or Aridol respectively. Don't worry, I will deal with that later on. It's mostly well tolerated and it has been around since 1960, so it's not a new medication per se. It has laxative effect because it's hyperosmolar and hypertonic, and that could lead to diarrhea. But don't worry at all because the amount in candies and gummies as diluent in tablets and capsules will not cause this, except when you then take those items in large quantity. If there's no renal flow, then no Mannitol. Don't worry, I will talk more about this as we continue because our good intentions should not turn to be harmful to the people that will be using this medication. Before starting Mannitol at all, watch the fluid status of the person to take it. It must be corrected. Okay, if there is blood loss, must give blood. If the BP is down, hypertension must raise it up. And then we must have renal function test done. Still, part of my note to glance through will include diving deeper into this topic. Systemic Mannitol is used more than the inhalation or per-oral forms. It's all about osmotherapy, okay? Salt-based, when it comes to osmotherapy, it's either you are dealing with salt-based osmotherapy. In that case, it will be Hypertonic Saline. Or the osmotherapy, what you want to use as osmotherapy will be sugar-based. In that case, it will be Mannitol, that is Hyperosmolar and Hypertonic. The hypertonic saline or hyperosmolar mannitol will be needed to draw the edema across blood-brain barrier, that is in cerebral edema, right? Increase intracranial pressure and so on, okay? We have to avoid mannitol if serum osmolality is greater than 20. Remember, I have said mannitol on its own is hyperosmolar. So when osmolality is already greater than 20, keep the mannitol away. It is not the only way to treat cerebral edema or the only way to treat increased intracranial pressure. No. What are the other ways? Don't worry, in a bit, I will go through all of them. Mannitol increases the cerebral blood flow. Well, is that advantageous or detrimental? You will know in a bit. It may be dangerous to the kidney, so correct hypotension before you use it. And in anuria, no mannitol. It could be injectable, osimetral, or irigan resectizole, another irigan cystosol. It could be per oral by inhalation under the brand name Aridol or Bronchitol. Aridol for bronchial challenge test to diagnose asthma. Bronchitol as mucolytic agent in cystic fibrosis. Class is a sweetener and a medication. As a sweetener, is a sugar, alcohol, and isomer or sorbitol. A sweetening agent even for diabetic mellitus patients, and with that, it doesn't raise blood sugar. As a diluent in tablet and capsules to mask the bitter taste, as vehicle or bulking agent for the same purpose. Okay, so it's used in gums and candies. Excessive consumption of mannitol will have laxative effect, but the good news is in candies and gums and as diluent, we use small amounts, just for coating purposes. And that will not likely lead to diarrhea, except you consume those agents in large amount. And they themselves might even be the ones causing the diarrhea. Okay, as medication, that is why many people will click on this. I don't think anybody will click on this for the purpose of mannitol as coating agent for gummies and candies. I don't think so. So as a medication, we use it as per oral mannitol as mucolytic agent, respiratory diagnostic agent to diagnose asthma, bowel preparation for colonoscopy. The systemic mannitol is under miscellaneous diuretic or osmotic diuretic, also for genital urinary irrigation. The per oral mannitol. This will afford me the opportunity to delve deeper into mannitol being used as per oral agent. The per oral mannitol. The per oral mannitol is either a mucolytic agent. In that case, bronchitol will be useful in cystic fibrosis, right? Then it could be under the class of respiratory diagnostic agent. In that case, Aridol, as an example, will be helpful in bronchial challenge test to diagnose asthma. Some use it in bowel preparation for colonoscopy. If you want full information on per oral mannitol, you can click on this very link. I have a separate presentation already published on that. Now, forms of the per oral mannitol. Capsule for inhalation as bronchitol. That could be 40 milligram. BTT means bronchitol tolerant test. That must be done before administering bronchitol. I'll go into that in a bit. Or kit for inhalation as Aridol 0 milligram, 5 milligram, 10, 20, or 40 milligram. This is helpful in bronchial challenge tests to diagnose asthma. Uses of per oral mannitol. Cystic fibrosis maintenance. I've said this repeatedly. Bronchitol will be helpful. In diagnosing asthma with bronchial challenge test, Aridol will be helpful. In bowel preparation for colonoscopy. Mechanism of action. Not so clear, mechanism. But we are sure it has bronchoconstrictive capability and can improve lung function. If that is not the case, bronchitol will not be selected to be used in cystic fibrosis. As an osmotic agent, bronchitol will draw water into the airways, thereby loosening the very sticky mucus found in cystic fibrosis. Administration. I will not rush through this. I'll go through each of these medications one by one. Number one, bronchitol. Bronchitol is never going to be given to any child. Don't give it to a child. Even if the child has cystic fibrosis, it is until age 18, okay? Because we cannot know more than the manufacturers, okay? So they will not allow us to give it to children. Anyone that will take bronchitol must be 18. For cystic fibrosis to help in clearing the mucus, and should be inhaled, not to be swallowed. It is a dry powder. We must have pulmonary function tests done through spirometry before bronchitol tolerance tests. Bronchitol tolerance tests must be done before you give bronchitol, okay? I've said that as a repetition. I'll not go over that again. The mechanism of action of bronchitol is essentially that it's an osmotic agent. So it draws water into the airways, thereby loosening the sticky mucus. And then the individual with cystic fibrosis can expectorate. We have to use Ventolin inhaler, that is short-acting beta-2 agonist, before administering Mannitol. Okay? Then we can give it in the morning and also at night, but at least 3 hours before bedtime. The individual must exhale fully, then administer the medication with closed lips and take a deep breath, with that breath being held for about 5 seconds, okay? Then repeat if the powder is left in the inhaler, meaning you exhale fully again, then administer the medication with closed lips, take a deep breath with it, and hold that breath for 5 seconds. Then we must replace the inhaler every week. After that, do your spirometry again. Still on administration, but I've moved away from bronchitol. Now Aridol. The number 2, Aridol, is a dry powder mannitol capsule, never to be used by anyone that is not an expert, so must be used by expert only. Before administration of Aridol, spirometry should be done. We will need Aridol for bronchial challenge test. The bronchial challenge test is useful in the assessment of bronchial hyperresponsiveness to make full diagnosis or definitive diagnosis of asthma. The bronchial challenge test will help greatly in some other ways, but if you want to know fully what bronchial challenge test is all about, besides diagnosing asthma, and how we can even go about it and use it to make full diagnosis of asthma, click on this very link. I have a separate presentation of about 22 minutes on bronchial challenge test. It's not Aridol alone that we can use for that purpose. You can use Metacoid, you can use S.M.is, you can use some other stuff. Find out. Unlike bronchitol, you don't need to do bronchitol tolerance testing here. This could be given to children. Remember, bronchitol can never be given to anyone less than 18. These Aridol can be given to children, but not anyone less than 5 years. Some authorities will agree it must be 6 years. Some will say it must be greater than 5 years. But we can all come to the midline. Nobody younger than 5 can take Aridol. Still on Aridol, we must measure pulmonary function test 1 to 2 minutes after use. We can repeat Aridol until we are able to obtain positive response or we've reached the maximum dose of 625 milligrams. Again, I've decided to put it back here. Only experts can use this. Pretest avoidance. If you have to use Aridol for bronchial challenge test, you have to avoid certain things. No cold air before the test, no exertion. If you have an allergens that you have known, then avoid them before the test. No smoking, no smoke inhalation. Don't take any non-steroidal anti-inflammatory drugs, none. Don't use bronchodilators. No, let us know that your airway is resting. We have come to use the Aridol to provoke it. It's a provocation test, right? Transiently, if you're on oxygen, please, for a short moment, close to the time you do that test, you have to be off the oxygen, okay? Now, long-time use of corticosteroid is neither here nor there because even if you stop it, the day before the test, well, that would not really mean much because if you're on it on a long-term basis, stopping it for 12, 24 hours will not really make much difference. But it depends on the expert that will carry out the test. Adverse reactions. Dyspnea, rhinorrhea, laryngopharyngitis, dizziness, nausea, chest discomfort, cough. Remember, you are going to inhale it, right? Also, exacerbation of the pulmonary disease, exacerbation of cystic fibrosis, vomiting, hemoptysis, increased bronchial secretion, fever, bronchial constriction or bronchospasm. Contraindications. If there's a sensitivity to Mannitol or any of its components, we will not use it. If there's a sensitivity to gelatin, we will not use it. If bronchital tolerance test has been done and the patient has failed, no bronchital. No Aridol. If there may be bronchospasm, and someone will say, you are saying if there may be. Well, let's go through the conditions when we think there may be bronchospasm. If there is aortic or cerebral aneurysm, unstable angina, no cerebrovascular accident, hypertension or myocardial infarction, hemoptysis, recent abdominal or intraocular surgery, we will keep Aridol off the table. When pulmonary function test is not encouraging, is poor, no Aridol. No bronchital also, okay? In asthma or COPD, we keep these medications off. Warnings. Aridol may give us severe bronchospasm. We can repeat Aridol until positive response or maximum dose has been reached. It is contraindicated in asthmatic patients or anyone with poor pulmonary function test. We must get bronchodilators ready. Why that? For reversal of bronchoconstriction, that is short-acting beta-2 agonists, like salbutamol, generic, or Ventolin. No bronchial challenge test in anyone less than 6 years. Some will say you can do it in anyone greater than 5 years. Well, let's come to the midpoint or midline. Anyone less than 5, no bronchial challenge test. Still on one is when it comes to bronchital, we must have bronchital tolerance test before administration. We will not give it if there's bronchospasm, but note, there may be severe bronchospasm. Therefore, we must use bronchodilators before administering bronchital, even if the patient has passed the bronchital tolerance test. We must still administer bronchodilators. We have to be careful in those with hemoptysis, particularly when we don't know the cause of the hemoptysis. Be careful in renal impairment. As a matter of fact, in anuria, we will not administer it. Drug-drug interactions. To those who are familiar with my channel, it's the same right now. Contact your pharmacist or your clinical pharmacologist. They will help greatly. Monitoring is all about pulmonary function test. Before administration of Aridol or the bronchial challenge test, before administration of bronchital, even before bronchital tolerance test. That is before you give the medication fully. Force expiratory volume in 1 second. In duplicate 60 seconds post-use. Get O2 sat. Get FEV1 again during BTT if there is a hemoptysis and the individual is in bronchospasm. So, this is how to pulmonary function test, pulmonary function test. Systemic or intravenous monitor. I have a full presentation on systemic monitor already published. If you want to click on this and go straight to that, that's fine. This is the link to the full presentation on intravenous monitor. Without further ado, let's see what's happening when it comes to systemic or intravenous monitor. The systemic monitor is a miscellaneous diuretic. To be precise, an osmotic diuretic and some undergenital urinary irrigants for urinary irrigation by urologists. There's a full presentation on systemic monitor. You can click on this very link for that. My first note here on systemic monitor is not strange to you, right? So this is it at a glance. You can pause and go through, but let me spend some seconds to say systemic monitor is used more than the per-oral monitor. It's all about osmotherapy. When it comes to osmotherapy, you go to through directions. It's either it is salt-based osmotherapy, we use Hypertonic Saline. Sugar-based osmotherapy, we use Mannitol, that is Hyperosmolar. Hypertonic Saline or Hyperosmolar Mannitol will be needed to draw the edema across the blood-brain barrier. We must avoid Mannitol when the serum osmolality is greater than 20. Remember, Mannitol on its own is hyperosmolar. This is not the only way to treat cerebral edema or the only way to treat intracranial raised intracranial pressure, but I will go into that right now. Just give me some few minutes. We'll reach there. Mannitol increases the cerebral blood flow, but may be dangerous to the kidney. Therefore, we must correct hypotension before using systemic monitor, and we cannot use this medication in the face of anuria. Uses mostly for increased intracranial pressure reduction or cerebral edema treatment. It is not the only agent for reduction of increased intracranial pressure or treatment of cerebral edema. And I've written it down here that I must give further explanation on this. Yes, when there is increased intracranial pressure, the first thing first, we must elevate the head of the bed to 30 degrees. Then you may decide to choose your Hypertonic Saline if you are going for osmotherapy, because there are two ways, either medical or surgery, medical before surgery, and so on. So Hypertonic Saline or Mannitol, that is hyperosmolar. But some will hyperventilate to induce hypocapnia, although there's a controversy around that. Some felt that would be cerebral ischemia, and hypoxia. Some will use urea, some will use glycerol, some will combine Mannitol with high-saline diuretics. If it is subarachnoid hemorrhage, some will not even waste their time, they'll just go straight to nimodipine. And when the technical know-how, the personnel on ground like neurosurgeon, some will go for surgery right away. It depends on what is obtainable in your jurisdiction because there are so many stuff that could cause increased intracranial pressure. CT MRI will help in making that determination. Uses again, so it's not only in increased intracranial pressure or cerebral edema, also in increased intraocular pressure. But before coming down to Mannitol, try other means of treating intraocular pressure, or you just refer straight to the ophthalmologist. In hyphema, that is accumulation of blood in anterior chamber. You can use Mannitol, but have that conversation with your ophthalmologist. Increase intracranial pressure, repeating itself, cerebral edema, repeated already, brain abscess. Systemic Mannitol is good for acute tubular necrosis prevention if it is given before revascularization during kidney transplantation. Both the donor and the recipient will receive this. We'll delve more into that later on. It is, however, contraindicated in severe renal impairment. As a matter of fact, when there's anuria, no Mannitol. We have to be conscious in anyone with underlying renal disease. Although we've said it is good for acute tubular necrosis prevention, but see, the fact that we've seen green light sometimes doesn't mean we can go. We still need to look, left and right before we move out. If not, if you're at T-junction and the light is green and somebody is not obeying the traffic rules and is crossing the red light the other side, he or she can hit you. So a test dose is necessary pre-administration in oliguria. Oliguria, to those who are not physicians and nurses, oliguria means you are not producing enough, you are producing small amount of urine. If you are not sure of the renal status or you are querying renal failure, have a test dose. So test dose in oliguria, not sure of the renal status, query renal failure, have a test dose. Oliguria or acute renal failure prevention and treatment, IV Mannitol will be helpful. In genital urinary irrigation, helpful. In kidney transplantation, for both the donor and the recipient, Mannitol will be helpful. Still, some other conditions would include burns, bleeding, shock, transfusion reaction, trauma, and even in amphotericin B to prevent nephrotoxicity. Intravenous Mannitol will be helpful. When used with high-cylinder diuretics, it is very helpful in eliminating certain poisons like barbiturates, bromide, acetylsalicylic acid, or imipramine. It helps in eliminating uric acids, preventing hyperuricemia, post-chemotherapy, or post-radiotherapy in oncology. So, very helpful, right? In ascites, when you are trying to drain, you can use Mannitol with other diuretics, like aldosterone antagonist will be very helpful in ascites, right? Like spironolactone. But you may choose high-cylinder diuretic like furosemide or methazoline to be combined with, Mannitol. But there are so many things to watch. Electrolytes and the fluid status. Okay. Forms. Solution for irrigation would be Laxative 5% or Cystosol 3% hexitose as Mannitol sorbitol in water. For intravenous solution only, when I said only, it means you cannot give it intramuscularly or subcutaneously. So for IV only, you can have Osmotherapy 5%, 10%, 15%, or 20%, or generic Mannitol at 20 or 25%. Mechanism of action. It produces osmotic diuresis and can reduce viscosity. Water is drawn from the brain and is excreted in urine. Of course, if that is not the case, who would then use it? I mean, if the water is drawn from the brain and is not excreted in urine, who would then use it? Administration. This is pretty important, so I'll not rush through it. Please give IV Mannitol only by IV. No IM, no subcute, and must be given very slowly. Some physicians will actually specify the length of administration. They can say for 1 hour. 1. To dissolve any crystal or crystals found. If you are given the strength that is 25%, then don't use polyvinyl chloride baths. Why that? It may form precipitate. Don't give this with blood. Why will you not give it with blood? It can form agglutination or crenation. You must use a particular given set, the fetal type, for this IV administration. If systemic Mannitol is greater than 5%, use large veins. And I've written the question here. You should ask me why. And I'll give further explanation right now. When the strength is greater than 5% and there is extravasation, Mannitol is a vesicant, meaning it can form blisters and is highly irritating. No human being will want that, right? So we do everything to prevent extravasation, because extravasation will be irritating and could lead to blisters. And when it occurs, if extravasation should inadvertently occur, don't rub it, don't wipe it, no, use hyaluronidase subcutaneously or through intradermal route using tiny needles like the type we use for tuberculin skin testing or insulin. Yeah. Hyaluronidase here that will be given subcutaneously or via intradermal is the antidote to Mannitol that could be extravasated on the skin. So it is the antidote. When there is oliguria, you have to give a test dose for 3 to 5 minutes. Remember, we said that earlier, that in the face of oliguria, don't give the full dose. No. Give a test dose for 3 to 5 minutes. In anuria, we are not going to give it at all. If you are not sure of the renal status, give a test dose. If you are querying renal failure already, give a test dose. But don't give full dose. Irrigation could be given through certain instruments, that is, urological, instruments. Okay. Contraindications. When there's sensitivity to Mannitol, we will not give it. Anuria, I think I've said it about 5 times today, right? We will not give it. In severe hypovolemia, please make sure you rehydrate. In active intracranial hemorrhage, no. In pulmonary edema or pulmonary congestion, no. Why that? Very soon we'll go through adverse reactions and we'll discover that we can even get pulmonary edema from the use of Mannitol. So it's not working like furosemide, right? No, they have different mechanism of action, and each is useful differently. Still on contraindications, it is contraindicated in severe renal impairment. In fact, nephrologists will be happy with us if we don't put all these things into consideration. Be cautious in anyone with underlying renal disease. A test dose is necessary pre-administration in the face of oliguria. If you are not sure of renal status or you are querying renal failure, someone will say, you've repeated this, you said it earlier, because it is important. That's why I've decided to bring it out again. Now, drug-drug interaction. As usual, contact your pharmacist or clinical pharmacologist. monitoring, renal function test, fluid in and out, serum osmolality will help in monitoring. Adverse reactions, yeah. There may be fluid overload in the heart, leading to heart failure, the chest pain. There may be edema. Remember the other time I said you will not give it in pulmonary edema or pulmonary congestion. You can now see why. Pulmonary edema or pulmonary congestion can be the case. And then we'll be looking for high cylinder arrest like furosemide, ethaclinic acid, or bumetanide. There may be rebound intracranial pressure, rebound increased intracranial pressure. I'll get into that in a bit. There may be dehydration. Of course, what do you expect? When there's diuresis, the fluid is being lost. If there is no replacement, of course, there'll be dehydration. There may be electrolyte imbalance, dry nausea and vomiting, thrombophlebitis. Remember, extravasation can also give thrombophlebitis. There may be chills, coma, or dizziness. It may lead to seizures, pruritus, rashes, urticaria, can lead to hypertension or increased heart rate. Acid-base imbalance will be the case. There will be hemoconcentration. When the fluid is out, there is dehydration, then there will be hemoconcentration. Anuria. So in those with severe renal impairment, then they may end the journey. Hematuria or fever. There may be blood vision, cough, myalgia, or muscle rigidity. Warnings. Monitoring for mannitol toxicity is essential, and we can use serum osmolar gap to do that. What we expect is anything between less than 18 to 20. That's why it is being said that when the osmolar gap is greater than 20, we don't use mannitol. Still on warnings, mannitol is a vesicant, so it can cause blisters by inadvertent extravasation, right? May cause cardiac overload. Remember, we've seen heart failure and other adverse reactions, and can cause pulmonary congestion. Remember, we're seeing pulmonary edema. There may be fatal hypersensitivity. So when there's hypersensitivity, we have to be very careful. We should not even come close to mannitol because it can lead to death. There is likelihood of nephrotoxicity. We have seen this. I have said it repeatedly. When there is renal impairment, severe renal impairment, don't give it. In oliguria, give a test dose before. In query renal failure, give a test dose. Just run away. In anuria, don't give it. Fluid loss, dehydration, hemoconcentration is a possibility. Of course, it's a diuretic, right? Now, osmotic diuretic. What do we expect? We expect the electrolytes to be lost, and we have to be careful in renal impairment. 24 to 48 hours after brain injury in pediatric age group, there may be intracranial hypertension secondary to generalized cerebral hyperemia. That is when mannitol is administered. There may be increased blood flow that can lead to bleeding post-neurosurgery in pediatric age group. So if the pediatric neurosurgeon decides to use mannitol, there may be increased blood flow that can lead to bleeding after the surgery. And these two conditions can lead to rebound increased intracranial pressure. Other central nervous system complications could include coma, confusion, and lethargy. So sort of, in pediatric age group, we'll keep an eye on the impact of this medication on the central nervous system. Some examples. I've just decided to put on some examples that will not suffice to lead you to prescribe it in this manner. No. contact your pharmacist, contact your clinical pharmacologist at any time you are confused and you want to use Mannitol for any reason or reasons. And you can contact specific specialists in the particular system that you want to use it for. For example, if you want to handle increased intracranial pressure or you want cerebral edema treated, then you can contact your neurologist or neurosurgeon in your jurisdiction, in addition to whatever you can do with a pharmacist or clinical pharmacologist. So in that case, this strength might be the beginning, okay? If it is about irrigation of genitourinary region, contact the nephrologist, urologist, okay? Then you can use this strength. When it is kidney transplantation, of course, the transplantation will be done by expert, right? The donor can get as high as 12.5 grams with IV fluid. The recipient will get more than that, as high as 50 grams. In increased intraocular pressure reduction, involve the ophthalmologist, but you may go for this. Lastly, contact a pharmacist, please. Contact your clinical pharmacologist, please. With that, I've come to the end of this long presentation on Mannitol. We've seen from A to Z how Mannitol has been around for a long time. It's an isomeric sorbitol, a sweetening agent, and a medication. In cystic fibrosis, bronchitol will help as a mucolytic agent. In diagnosing asthma, Aridol will help for bronchial challenge test. In increased intracranial pressure or cerebral edema, intravenous Mannitol will help. For irrigation of genitourinary system, yes, some forms of Mannitol will do that. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.